When I'm speaking about palliative sedation, you can give me the next slide. I always give some definitions because palliative sedation is a part of the end-of-life care. You can give the next slide. So it's a part of medical assistance at the end of life. And when we speak about medical assistance at the end of life, we can say that these are the different ways in which healthcare in general and medicine in particular accompany the end of life. And it is what doctors do and certainly sometimes don't to accompany the patient's death. And this can sometimes be life shortening or life's prolonging, but it is not it has nothing to do with life shortening of life extension, but with the quality of life at the end of life. Next slide, please. When we speak about end-of-life medical decisions, then we have three possible forms of decisions. We have the treatment decisions, and that can be some treatments that will be installed, but it can also some treatments that will not be started or not continued or stopped. The second part of decisions that we can take at the end of life are the treatment, the palliative treatment that can start with symptom controls. And a third kind of decisions are decisions on active termination of life. And that can be assisted suicide, euthanasia, or termination of life without request from the patients. The two first kind of decisions are accepted as normal medical practice. The third kind of decisions are very controversial. And as all know, euthanasia is accepted in some countries, also in Belgium, also for children, but that's not the case in a lot of other countries in Europe and in the world. Next slide, please. Next slide. To make a decision, you have to be competent, and that's not always the case in children, especially not in chronically ill children with disability, where we are confronted with a lot of those children, not in children with cancer, but especially in the other part of children that we also treat in our palliative care team. So even in children, where you speak about taking decisions and involving children in those decisions, we have a competency assessment that is important. What are the conditions that these decisions will take in? That's also not always very clear. And who will take the decisions and what are the standards? So next slide, please. For non-treatment decisions, I think that former speakers has already touched that problem. And I think that advanced care is an essential part of the whole trajectory in a chronic disease. So I think advanced care planning is very important also when you have to take at the end of life very important decisions. When you have a good advanced care planning, it will be much easier, it will be much smoother, as communication is already done, will be very important. Next slide, please. Pain and symptom control are the cornerstone of palliative care, and I think also in palliative sedation. Palliative care, as I think everybody knows, is an active and comprehensive care, interdisciplinary, very supportive, and the quality of the patient and the family are the center of the care. Symptom control is more than just pain treatment, and the pain management is, as we know, administering analgesics and other medication in dosages and combinations required to control pain and symptoms. And we will increase it when pain will increase, and the increasing of the dose is proportional because the pain increases. Next slide. But pain is much more than only physical pain. The pain treatment remain the first object, and there is still a major ethical problem in undertreatment of pain and discomfort in palliative care. But there still is a lot of confusion about ending active the life when increasing medication, when starting certain medications. I think every palliative care doctor will be confronted with those ethical problems and ethical discussions at the end of life. Next slide. Palliative sedation is a situation where, in exceptional cases, symptoms may not be adequately controlled, and it is lowering the level of consciousness in refractory symptoms. The dialogue with the patient and representatives are very important, and there are very different forms of sedation, from mild to deep. It can be intermittent to continue, and it can temporary or not. Next slide, please. One of the issues, and we will see that this is also important, is when you do palliative sedation, will you continue to give food or fluids? And that's often one of the major discussions that we have with patients when we start, and parents when we start palliative sedation. If you give no artificial food and fluids, is that life shortening? That is important in taking the right time to start palliative sedation. We see that when we start palliative sedation, we will do nearly the point of dying. So in the not more than 1 week before dying. So it's often close to that, and to the end of life shortening effect is very small. And the vast majority of patients have already stopped eating and drinking at that stage. So next slide, please. There are certainly some definitions that you can find concerning palliative sedation. So it is the monitored use of medication intended to induce a state of decreased or absent awareness and consciousness to relieve burden of otherwise intractable suffering in a manner ethically acceptable to the patient, family, and also healthcare providers. The definition of the EAPC is that it is an intervention aiming to alleviate intolerable suffering resulting from one or more combination of symptoms, and it is an intervention that is monitored and deliberated, differentiating it from situations where sedation is a side effect of treatment. Palliative sedation is an important medically and ethically acceptable intervention for patients with intractable physical, psychological, spiritual, and existential distress refractory to all forms of relief. And we see that there is an increase over time. Some reports in Switzerland mark that there is an increase in prevalence from 4.7 in 2001 to 70.5 in 2013. that means in adult populations. And international literature shows an increase from 3 to 10 between 2006 and 12 to 18 between 2006 and 2019. Next slide, please. So it has to be alleviate refractory symptoms in terminally ill patients, and all means of standard therapies have been exhausted. The monitored use of medications intended to induce a state of decrease or absent awareness in order to relieve the burden of otherwise intractable suffering. The level of sedation, as we already mentioned, can be very different, and it is continuous deep sedation until death is indicated for terminally ill patients with a very short expectancy of life of some days or hours, and it is not intended to hasten death. Next slide. So it is an integrated part of end of life in many countries, but there are many or no structured legal frameworks in most countries, except in France, where there is a law, but we will see, that allow the use of sedation in all layers of population, so also in children. Next slide. There are some guidelines that have been published, and you can find 29 recommendations in 14 countries. The issues that are mentioned there is who takes the decision, the mode of death, and also can you use some scales to measure it? What is refractory suffering? Also not always clear. When to start palliative sedation? What about additional therapies? And how to monitor palliative sedation? Next slide, please. Very important is communication before palliative sedation. And I think that advanced care planning is very important there. So involvement of patients, substitute decisions makers, family and whole care team, and the whole care team with respecting the patient's choice is important. It's very important to prevent misinterpretation of the emotional situations. Palliative sedation is very different from euthanasia, and I think sometimes it's very important to stress that. Clarifying palliative sedation is for the suffering of the patient and not for the family. Family communication should include several elements. The family's level of knowledge about the prognosis, the wishes regarding end of life of the patient is very important. So a good advanced care planning here is very important. Healthcare providers should discuss the goals and the priorities, the intolerable distress levels, and the treatment options that are possible. Patients and families should be assured that cultural and personal wishes will be respected with ethically and legally, when ethically and legally feasible. It's very easy to write this down, but we have a lot of discussions about those issues when we install palliative sedation, because we all treat, I think, people from a very different origin, and we have to respect as most as possible wishes from all those people. The aim, the process, and the risk of the palliative sedation should be discussed, because people have sometimes very I would not say strange ideas, but people think sometimes that when you install palliative sedation, the patient will dying in a few hours. That's not always the case, and we have to instruct patients and also certainly families that sometimes it will take some days and sometimes um, sometimes a week, certainly in children, even when we have to deal with children who are very chronically ill, because children have usually very strong organs. They have a very strong heart, and it is not like in adult older patients. So sometimes we have a palliative sedation period that takes a long time, and that's quite a burden for families, but also for caregivers. And the main aim of palliative sedation is to alleviate the patient's suffering and not to ease other needs. It's not for, well, it's certainly to support um, the family, but we always have to put the patient central. So before starting palliative sedation, families should have the opportunity to communicate and say goodbye. Next slide, please. The definition of refractory symptoms is also not so simple. It is intractable, is untreatable for the healthcare provider and intolerable for the patient. Unacceptable of providing adequate relief. And I think that's also very different from patient to patient. When we see some adolescents with cancer, we see some very, very suffering patients who wish to do that, and which is sometimes very difficult for their family and also for the healthcare providers. But if that is their wish, we have to respect that. Associated with excessive and intolerable acute and chronic morbidity, and unlikely to provide relief with a tolerable time frame. Mentioned in the 16 publications, the most frequent intractable symptoms are delirium, I think in elderly patients, pain and dyspnea. Less common are vomiting and nausea, epileptic seizures, agitation, hemorrhage, asphyxia, bronchial secretion, and fatigue. Next slide. This is a scheme or a kind of checklist that can be used before starting palliative sedation. And you cannot find a lot of those things for pediatrics, but I found one. Next slide, please. And that's one of St. Jude. And I think it's one of our goals, or it should be one of our goals, to develop also such kinds of instruments and algorithms to use in the pediatric palliative care. Next slide, please. What kind of medications will you use when you start palliative sedation? Opioids should not be used to start palliative sedation, but mostly, certainly in cancer patients, patients will already use opioids, and they should not be stopped, but they cannot be used to induce palliative sedation. Mostly, I think midazolam is used in monotherapy continuously, intravenously, or in subcutaneous infusion. And there are recently some reports to use other medications like dexmedetomidine or levomepromazine or propofol. Next slide. This is what we use when we start palliative sedation with our patients in hospital or at home. Next slide, please. There are some there is some literature about monitoring during palliative sedation, and some scales that can be used to monitoring the depth of the palliative sedation, but I think they are not yet used in pediatric settings. Next slide. Next. I found one existing guideline for palliative sedation published by our Dutch colleagues. You can find it and you can read it. Next slide, please. And so in France, there is the only law where palliative sedation is legally allowed for all patients, also in very young patients, leading sometimes to some ethical issues, especially when this kind of practice will be used in patients with very severely neurological problems after, for instance, a traumatic issue, and where you will see that you will not start, or you will withhold life-threatening, life-supporting treatment because there is some concern about the neurological state of the child or the patient after giving that treatment. So for a lot of physicians in France, when they are confronted with that problem, they will have some ethical and also moral distress about those decisions they have to take. Next slide, please. The decision is not always very easy, and when you do some literature about that, you see that it is a complex iterative process, and it is a shared decision between patient and healthcare professionals. So I think I have to go a little bit quicker because otherwise I will be out of time. So I will try to end by the case, because I think I have a case report and I think that's important. You can continue with the slides, please. Go on. I will, yes, go on, go on, go on, go on, go on. Otherwise it will take two. Yeah. Oh, go back. So I have put in a case report from a 14-year-old girl that was diagnosed with an osteosarcoma. And she was treated according to a known protocol for osteosarcoma. And 1 year after, more than 1 year after diagnosis, she relapsed with lung mets, for which intensive chemotherapy was started. Next slide. The family background is important because she came from, well, a normal family, if you can call a family normal. She has a 14-year-old brother, and the family was originally from the Netherlands and moved to Belgium. So they had not a big a network in Belgium. It was a very dynamic family that were communicating quite well. And she has had some individual conversations with psychologists, and she could also have conversations about difficult themes. Next slide. After 2 courses of intensive chemotherapy, there was an evaluation, and the evaluation showed that it was not well. And so there was made a choice for comfort. But she didn't feel well. She has a lot of pain. She has fever, nausea, and the parents wishes to start an alternative treatment, Votrient, because they could not stop treatment. She was well aware of the consequences of the relapse, and and that she had limited perspectives, and so she decided for herself what she wants to talk about and when. And she was quite sure about things that she wished to talk and what not to talk. She wants to go home, and especially do fun things. Next slide. Or uh, palliative care um, um, liaison team was involved, and we try to get everybody on the same line, especially with attention to her last wishes. Next slide. And you see that was in December. We start the palliative care process with installing comfort therapy. Next slide. And we had a lot of difficult discussions, and especially the talk with her mom, who wishes to talk with the patient about her death, but the patient didn't want to talk about that with her mother, was very difficult. Also, she would like to have more comfort and a hospital bed, but her parents didn't want it. So there were a lot of issues and wishes that were not in line each with another. And that was in December. So next slide. She had a lot of additional discomfort with nausea that was very difficult to handle. Next slide. Also in December. We started morphine intravenously. Next slide. And you can continue. There were a lot of difficult discussions also about extensional questions. Next slide. And it took, you can go on, it took until the beginning of March to start after very severe intractable pain, but also after good discussions between the patient and the parents to start palliative sedation. Next slide. Where she died a few days later. And next slide. So we can conclude here that this was a family that communicated very openly and directly. We believed that in the palliative setting and at the end of life, all themes could be discussed openly. After the palliative sedation, the attitude of conversation, the attitude of the patient changes a little bit, and extensional questions and fears were much on the agenda, but she decided when she wants to discuss it and when not. And often she does not want to speak, but just do. The parents deal with the fact very differently, as well as with the deterioration, the pain and the suffering and needs for many conversations together, but also individually at all times of the day were um, necessary. Also, the brother needs a special guidance. And after her death, parents are very happy that they respected her choices, and they are convinced that she was able to take and keep the scenario for her life and that into her own hands. Next slides. So I conclude with the remaining problems, and I think there are still a lot of remaining problems. The uncertainties regarding definitions and practice, inadequately trained and inexperienced healthcare providers, national and international guidelines are needed. High quality research is limited in this field and is also needed. There are a lot of legal concerns. What about incapacitated patients? And I didn't touch the issue, but there is special attentions to the neonates, where we also have some very difficult questions. And I think that's it.
Thank you very much for this nice presentation, Marlene. There's one question in the chat. Olivia has a question about the case regarding where the sedation happened. Was it in the hospital or hospice? And did she die at home or in the hospital?
It was at home, and she died at home. We don't have a lot of hospices in Belgium for young people, and most of our patients, practically all of our patients, died at home, and we perform practically all our palliative sedations at home.
Maybe one question of myself related to that. How do you train on more short notice the caregivers at home to perform the palliative sedation?
Yes, but that's, I think, the advantage of our liaison team, because we are we have quite some experience in our liaison team. And the goal of our liaison team is to support the caregivers at home to do this difficult task. I think it's not possible to train the whole, we call it first line, in that issue. They will practically normally never will be confronted with a difficult situation like that, certainly in children. It's as we are a liaison team and as we are the connection between the hospital and also mostly the caregiver that has known the child for the whole chronically ill period, they can support the physician at home and the nurses at home in this difficult task. And the liaison team is present 7 days on 7, 24 hours on 24 hours. And we do it always with the material from the hospital. So we provide the pumps, the PCA pumps, the material, the medication. We provide that.
Okay, thank you. There's still one question in the chat from Irina. Is mechanical ventilation allowed in palliative sedation?
I think there is some literature about that, how to perform mechanical ventilation and palliative sedation. But yeah, that's difficult. When will the child or when will the patient then die? I think you have to take some decisions at some moments, but there is some literature about that, but I didn't read it all. Yeah.
Okay, thank you very much. I don't know if anyone else still has a question.
I was just wondering, I had a question regarding the the medication that is used. You mentioned midazolam is probably the most used one, but you also mentioned that Dexdor, propofol, or levethromycin is also used sometimes. Is that a common is that commonly done? Because I'm thinking that
No.
in most cases, I think most physicians would be quite weary of using these drugs because of the doses and because they don't know
Yeah.
the effect so well. How do you think we should overcome that if it's better than midazolam itself, like
I
Dexdor, for
think,
instance?
I think, well, perhaps that's something that we have to look for and to examine. I think most patients or most physicians have experience with midazolam, but the Dexdor is something from the last years, and perhaps that's something to look for. I think in neonatal care that they use sometimes other things, and also in intensive care units, but that are quite some different environments and situations. I think that propofol is used certainly in neonatal care and also in intensive care. I've used it once in a dying child with a brain tumor where you have some very nasty symptoms, some that are very intolerable for parents. But I think when it's possible, then I think that midazolam is a good medication to do it and to titrate. Yeah.
And maybe last question from Yasmin.
Hi, I just wanted to share what we do in our center, basically in UK, Nottingham. So we discharge patients when they are end of life, and we have like a symptom management plan, including midazolam, levomipramazine, ketamine, sometimes subcut, and we have a community support, and there is a community team who after we prescribe these medications in the drug chart, we send these to the community team, and we prescribe all the medication, and they know how to escalate the doses. And we already prescribe the escalation. In the symptom management plan, we follow the formulary for the dosing for midazolam, ketamine, and levomipramazine, and sometimes we add diamorph. And then community nurses or team who they are really trained to deal with these pumps we give to patients when they go home. They can do like daily visits and assist patients, and based on that they can escalate and feedback to the medical team if there is any concerns. And this is something like in daily basis as part of the palliative management we do.
I think that's quite good if you have a good scenario, but in short of time, I could not go into the difficulties psychological to doing palliative sedation, because also for the healthcare provider and also for the families, it's a lot of emotional burden still. Also for the primary healthcare suppliers to do this, they need some guidance, I think, from people who are experienced and who tell them that they do the right thing, because yeah, it's not easy, even if we say it's easy. Yeah.
Thank you very much. I think maybe we be a bit on time that we continue with our next speaker. I don't know if Ulrike is already present. Yes. So Ulrike Leiss is a clinical psychologist, specialized in the field of pediatric psycho-oncology and pediatric neuropsychology. She's been working in the pediatric neuro-oncology unit in Vienna since 2001, both in the field of the inpatient psychosocial care and in long-term follow-up care. And today she's here to educate us on the psychological support and coping of patients and family.
Thank you very much. I hope you can see my slides well. Okay. Yeah, I'm really happy to give you an overview on psychosocial support and also some coping strategies today. Of course, it will only be an overview, but maybe also good for further discussion. And also I brought you some material, also new material, and I hope this can be useful for you. So first of all, even if really a central element of psychosocial support is individual care, so a very individual approach, I want to have just some words on our framework. We do have very nice psychosocial guidelines in this field, and the things I will tell you now are really based on the guidelines you can see here. So first of all, the good thing really is that fortunately now we can say that most of the time, really most of the time, I would say psychosocial care is a part of the whole care. and is really involved and integrated. And this is, I think, a benefit for everybody, for the families, of course, but also for healthcare professionals. Better communication, we know that also from evidence, and also shorter ways, and so on. So this is really the good news, because this has not always been like this, and we really had some progress here. So always the question is, for whom can psychosocial support be? Of course, for the children, adolescent, young adults, for the family and the carers, also for the siblings, and if at all possible, for the grandparents. But also, and we also discussed this already yesterday in our small group, if it's possible, it makes so much sense to have psychosocial support for the environment, for example, for the schools. Children, adolescents spend so much time in the school environment. So of course, a seriously ill child has an impact on the system, on the teachers, on the classmates. So if at all possible, it really helps. And only like 1 or 2 hours of psychoeducation can have a great impact and benefit for all the others. And of course, psychosocial support can also be for the team, for healthcare professionals. It is not recommended that, for example, supervision should be from the social team member in the team. So this should be organized externally. But we all know this is really a difficult situation for everybody, also for every member of the healthcare team. So there's a lot of dynamics. There's a lot of dynamics about communication and so on. So this is really also a part psychosocial support should be. Some words about the setting. Talking about psychosocial support, we mean that this can be individual with one child, one adolescent, or a parent, but also, of course, in a couple setting or in a group setting. For example, if you think of bereavement groups, it can be inpatient, outpatient, but if at all possible, many families really prefer to have it to have psychosocial support in their home setting. So if there's a mobile possibility, this is really appreciated. And we also know that many also out of the circumstances prefer to have, for example, online meetings. And this setting can be true for all the care models we have. Very often the question is, when should psychosocial care start? And this is easy. We can only say very early on, because we all know that it's so important to have the trust and then to build on this trust, and everything, especially regarding communication and so on, will be easier if we start, if at all possible, early on. This is really important too. I think especially in palliative care, psychosocial care should be really uncomplicated. There should be easy access. It has to be affordable. It has to be proactive, and we really have to see that we reduce barriers, because we all know that there still is a high mental health stigma, I would say. So we know that many persons ask themselves, do I really need a psychologist? How could she or he help? Now they think I'm crazy too. So, and all this, we know that this is, we still have this taboo, and we still have this stigma. And many people ask themselves, where can I find somebody? And of course, we do not want to have this. So I think it's really our responsibility to make really this easy access and to make it uncomplicated for the families, because everything else will not be possible in this palliative care situation. Yeah, some words about kind of basic principles of psychosocial support, because talking about this, I really want to show you some examples what we do. So first of all, and this is really in every guideline you would look up, we try to be preventive because we try to prevent secondary problems. This would be true for palliative care, but of course for all also all the other things we do as psychosocials. It has to be family oriented, of course. So we try to activate family and social resources. And I want to show you just this figure talking about the family system. This is really just some symbols, but to show you what impact on the family can be. So we all know it can be that a family grows together in this situation, but it can be that a family tears apart. This can be between the parents, between the siblings, and so on. So this family system is so complex, and it's really worth to explore and to spend some time talking to the families and to understand, because then, of course, there will be more trust, and every communication will be easier in the end. Of course, and I already mentioned this, individual-centered. So we have to consider, of course, age, development, language, the cultural, religious background, and so on. And just to show you some examples, this is the reason why, especially for younger children, we really like to work with books, for example. So we really try to equip the families with materials to promote communication together. This is just an example of one book, The Duck, Death, and the Tulip, because children really like this. Also, of course, we do have those books in many, many languages, and there are wonderful books out there, actually, in recent times. This one on the right side, I'm sorry, it is in German because I didn't find a translation, but children really like this one. It's about the best funerals in the world. So this is also one of the points we discussed yesterday. Children really like to have direct language. They ask very direct questions, and this is most of the time not so easy, of course, for the parents and for adults, but this is how children see the world, and we have to just try to to be in their perspective. This is what I also like very much, because this is also, it is in German because this is really the original, but I try to guide you through it. It is an emotion machine. Children really built this machine and wanted to feed their emotions in the machine, and of course then they got a little present if they wrote their emotion on the little paper, and then about anger, love, their sorrows and everything, and then put it in the machine. So this also, and we talked about this yesterday and also today already, it is so important to have non-verbal ways of communication and of coping for children and adolescents. And this is just one way. And if we let them, children and adolescents can be really creative, as you can see, and then find their way to communicate and also to process and to cope. This is another example. Lego, they really have this edition on like Lego pieces to rebuild a funeral. So this is more for bereavement care, of course, and what you can see on the right side on the top, this is kind of a comfort box also for children. And we talked about this today already. Monica showed us Voicing My Choices. This is really very beautiful material to work with adolescents. And really also the studies showed it increases communication with family members and decreased anxiety about end-of-life planning. So this is really nice material, and it is available in some languages, but it could be even in more languages if we want to use it. So some of the other basic principles of our work are, of course, it has to be supportive and resource and problem-oriented. It's always about disease, the current life situation. So it's always about the now. Interdisciplinary, this is, of course, a key element. And we always try to promote communication, the right for information, and also participation. And one very important sentence of our guidelines for me is really that problematic processing reactions are not pathologized. So in the sense of a primary psychological disorder. So we don't, most of the behavior we see, of course, is normal, because this is really one of the most difficult situations in life. So this is what we first see. We try not to pathologize, but see it as attempts to cope. And of course, we need intervention. But this is really a difference in the attitude, I would say. So right here, you just see some of the tasks of psychosocial care, from crisis intervention, counseling, psychoeducation. And all of this is true in palliative care. And you can also see, of course, most of the time, many professional groups are involved. So for example, music therapy, art therapy. We know that this is really a benefit for the children, siblings, also the families. And we base all of this really on the biopsychosocial model. So we always try to see this complexity in here. Some words about crisis intervention, because of course this is what we have to do very often, and I'm sure you all know those stages of traumatic crisis. It is a really old model, I know, but it's still used a lot, and of course it has been adapted and updated a lot. And I just want to mention the first phases, this first shock, because it's always so important for us to be aware again and again that all those reactions, children, adolescents, and the parents, the families show us, most of them are just normal, because this is part of life. And for example, looking at the first shock, so really the start of the figure, we have to be aware that most of the conversation in this period, people don't know anything about it, like on the next day or 2 days after. This is also the reason for, as I experience, for some dynamics in the teams very often. But this is just a normal thing in life, that if you're in shock, it's really not visible from outside, but it's inside, and you can't memorize everything you hear. So this is I just wanted to show this figure to you, to remind us that these reactions are what traumatic crisis brings. And if we know about it, it's really a lot easier to guide the families through all this. And of course, the consequence of all this is that, and this is what you can see here, the methods of crisis intervention, they have to be like a quick start, an activity, a proactive approach. We heard that also before today. Flexibility of methods, focus really on the current situation. So all of this makes sense if we have this model in mind. And some words on communication now, because I told you this is really one of our main goals, to promote communication, and that to make really it easier for the families to communicate. Maybe you already know those guidelines. I know that they are quite old, but really we appreciate it so much in there. This is why I wanted to show them very short. So as you can see here, we have in there, children expect honest answers to honest questions. Do not talk about the child in the third person while the child is present, and so on. Also, learn to listen to what the child or the adolescent says and when and how they say it, and very often they say it in unexpected moments to maybe unexpected persons, also valuing their perspective and not judging it. So the guideline is really full of very valuable information. And what we did, we tried to update it with recent publications. This is just one example where really the same aspects turned out to be the clinical recommendations. So again, respect and validate the child, adolescent as the patient. Also about trust and transparency. And what we did was within the EU CAIS project, we took all the guidelines we found, also literature. We did systematic review of literature, and then we tried to develop pocket cards. We decided in a consensus group that this could maybe be a format that many can use. We did some Delphi surveys and consensus groups about on the content, and then you can see here this example. Pocket cards turned out, for example, about talking with young people about serious matters, and they are thought to be used with healthcare professionals, but also, of course, the families, the patients. It can really promote communication. We do have them in really several languages. And you have the QR code here if you want to have a look. So far we have really good feedback also from the families and really like to use them. Yeah, and just one last point. I'm not sure, do I have more time? Because I did forget to set my timer, I have to admit.
You still have a bit of time.
Okay, good. It's just for finishing up, because this is really one of the most important points for me. You can see here, number 6, respect emotions. And this is really what this is so easy and really changes so much working together with children. Because if you, this is just an example from yesterday, we talked about the spikes concept, and here there's another one, the nurse concept. But of course, also naming, understanding, respecting the emotion is really the content of this concept. And I want to highlight this respecting. If you imagine one child telling us, I'm afraid of whatever. And most of the time, unfortunately, the normal reaction in the world would be, oh, you don't have to be afraid, because this is what we wish for. We wish that children don't have to be afraid. But of course, and this is also, it was mentioned yesterday, this is not what helps. Because if you're afraid or if you're angry, you're angry. And it doesn't help that somebody tells you you don't have to be. So this is what then respect the emotion means, to say, okay, I see that you are afraid. We will try this and that together, and to talk about it, to explore. Children very often tell you the reason why they are afraid, and then it's kind of an open window, and it's so much easier to communicate. So just an example, very easy, but it's really a benefit for everybody. And just to close up, I show you some of our other pocket cards. So we do have tips on communication, also for the healthcare professionals, how to prepare, for example. Also very nice cards about the balancing act between fear and hope, also about the good and the bad feelings. And the special thing here really is that we tried to include all the literature we found and the guidelines, but the consensus rounds together with the patient advocates, the parents and the healthcare professionals were so fruitful, because yeah, we had the feeling now it's closer to the needs. Also the fine line between healthy processing and emotional disorders, for example, and also one about my right to grieve. So if you want to, you can look them up on the website. Also, if you wanted to have like a paper printout, because they're very useful to have it like this as a printout, you could just email us and we will be happy to send you some of the copies in the language you need. So thank you very much for your attention. And of course, I'm open for questions.
Thank you very much for this nice presentation. Is there anyone who has a question? Marleen?
Yeah. One of my experience, certainly in pediatric palliative care and certainly in adolescent pediatric palliative care, is that respecting the choices of adolescents is sometimes a great burden, a burden for, especially for parents, because, and it's always, well, it's not difficult to talk, but yeah, you have to know your patient very well, and you have to have him in your hands, as I can't say it well, I think, in English. Do you have some guidance there? Because yeah.
I know I think I know what you mean. Yeah, this is the most difficult thing, because there's so much, we need so much trust that people tell us, both sides, parents and adolescents, and very often, of course, I mean, and also it's so difficult for them to tell us if they would have a different perspective, right? Parents and adolescents. But if we reach this, this is really, then we can work with it. But it takes, yeah, just a lot of exploring and patience, and also do it step by step, right? Because it's not, we can't, if we are too fast, we lose one of the one side.
Yeah, but yeah, so sometimes I say, well, in younger children, the value of your palliative trajectory is depending on the parents, and I mean there, well, you have very different situations. You have parents where you can have a very good walk through this difficult, very difficult, and I call it sometimes inhuman way. And it's the same in adolescents. I have now 2 patients in palliative care, 2 adolescents. One I think is 20, the other one is 17, and they are so different in their trajectory. And I don't want to call it quality, but the quality of your palliative trajectory is very depending on the persons who are you working with. So yeah, it's always, yeah, I think,
because they bring all this from what they experienced so far, right? It depends on
also their personality.
Yeah, personality, and how you communicated about disease, for example, before, how you communicated in the family about this and that. So this is so, and yeah, I agree. This is probably one of the most difficult challenge for us as healthcare professionals, to guide either way.
Yeah, and it gives also, burden to the caregivers, to the healthcare professionals, because sometimes you feel quite useless and powerless to some situations, because their personality or their, and you try to respect the choices they make. So okay.
Yeah.
Any other questions? We still have some time. Yeah, I had one question myself, if I may ask. Yeah, what would your advice be on the psychological team for children and their parents or their surroundings? Do you use the same team? Do you use different teams? What would your advice there be?
For to get their psychosocial support?
Yeah,
you mean?
and their
Yeah.
trust and.
I think this is really individual too, in my experience, because this is really every family needs and wants it in another way. And sometimes families even tell us they need both. They need it like within the team and outside to have both views. But this, I don't think it makes sense to have this guideline for this, because this is really individual. In my experience, yeah. But the most important is to provide them with support and to make it possible. So also if one family would tell us, well, it's not possible for us out of many reasons, yeah, to have it like within the team, then we help to organize external services, for example, and stay in contact.
Another question from Marleen?
Yeah. Well, I think perhaps people from the UK can better answer or have more view on that. We have also in Belgium a lot of different cultures. And sometimes I feel that we lack psychological support from different culture or psychologists who comes from other cultures. Like, for instance, if we have a boy with an Islamic background, and we have very young female psychologists, that's an issue. Yeah.
Yeah, agree. Absolutely agree. And this is really a challenge to find persons also with the competence to do counseling for the families, for example. But yeah, we try to have a pool of also external services to respect those cultural things. Yeah. But this is a very important point, of course. Yeah.
Okay, maybe we continue with the next speaker so that we stay on time for the last session. So the next speaker is Dr. Sergi Navarro. He's the head of the Palliative Care and Complex Chronic Patient Department at the San Juan de Dios Children's Hospital in Barcelona. He's a pediatrician who is specialized in pediatric palliative care, and he is the leader of the Pediatric Chronicity and Palliative Care Research Group in his institution, and he will talk to us on the research in palliative care.
Good morning, everyone. I will share my screen. Yeah, I think it's everything okay. So, as said, good morning. Thank you for the invitation, and I'm happy to be here with all of you. As said, my name is Sergi Navarro. I'm the head of Pediatric Palliative Care and Chronic Complex Children in St. John de Déu Hospital, where you can see here in the main entrance of the hospital. And well, it's an honor to be here today, as said, to have listened other panelists and to share some thoughts on the role of research in pediatric palliative care. We are facing growing challenges, but also exciting opportunities as seen here those 2 days to improve this care through science. And well, before we begin, I'd like to disclose that I have no conflict of interest related to the presentation. The Palliative project that we will talk about has been funded by the Horizon 2023 program, but the views I will express are mine. Well, let me introduce just 3 or 4 slides of my hospital. Sant Joan de Déu is a maternal and children's hospital affiliated with the University of Barcelona. It's a private and non-profit institution, but is an integral part of the public healthcare system. And our missions goes beyond treating diseases. We are committed to caring for the most vulnerable using an humanistic approach to create a fairer and more inclusive society. Sant Joan de Déu, it's a hospital that has grown a lot and focuses on key strategic areas that you can see here: oncomatology and fetal medicine and rare diseases are, in our case, all these fields that pediatric palliative care plays a transversal role in ensuring a comprehensive approach to complex and life-limiting conditions. Well, here you can see an example of how we integrate PPC or pediatric palliative care into our hospital's strategic line. Is pediatric oncology. 3 years ago, we launched the Pediatric Cancer Center in Barcelona, a dedicated facility that enhances cancer care through research, innovation, and multidisciplinary collaboration. And within this center, we have also prioritized palliative care, ensuring that children and family receive the best support at all stages of the disease. And here, as you can see, the center includes 2 dedicated end-of-life rooms, let's say, providing a specialized, dignified, and compassionate environment for children in their, not only in the final stage, but also in the advanced phases or the complex situations. Let me just, I want to take a moment to thank my team for the commitment and hard work. It's a team that has grown a lot since 1991, that you can see here that it was created the pediatric palliative care unit. And then since then it has continuously evolved. Over the time we have integrated the care of chronic complex patients since 2012, recognizing the overlap in it and the importance of more integrated model of care. And today we are working towards more flexible and connected models, incorporating digital tools, as we will see, as an opportunity of research, and improving coordination between hospital, home, and primary care. You can see here, we'll talk about our just a brief ideas of our Catalan network. So why research in pediatric palliative care matters? Well, we all know that pediatric palliative care is growing in complexity, and well, many gaps remain. And more children are surviving with chronic conditions, but we still sometimes have lack of evidence to guide these cares, to guide this care, sorry. And research is essential to improve this quality of life. And this is why investing in research is not an option. We said we have to discuss this in our hospital. I'm sure is the same situation in yours. And research is not an option, and we have to advocate that it's really, really necessary for those children and families. And well, during those 2 days course, I'm happy to see that we have a strong research community in pediatric palliative care. And well, in Sant Joan de Déu, our research strategy is based on a long-term vision, clinical implementation and trying to diversify fundings for this research. And to advance pediatric palliative care, we are leading several key projects. And well, I think we will see that we take care of more than 350 children, and 1 out of 3 has oncological diseases. The other 2 out of 3 are with non-oncological diseases. And I think it's not only essential to research. Research is not only essential for pediatric palliative care, but especially for a pediatric hospital, as we take care for those or this extreme complexity, but also this can be applied for thousands of patients. And well, I will start just to highlight that technology is transforming how we deliver pediatric palliative care, and digital tools and AI-driven solutions are helping us create more connected, proactive, and personalized care models. And we will see just 2 slides to show you how Palliative and Home C2P2 are 2 key European projects driving this transformation. Palliative is a European research project funded by Horizon, as I said, and aiming to improve pediatric palliative care through early detection, symptom assessment, and advanced care plan. And it proposed to solve those or to meet the needs with digital tools. And after 1 year, we have advanced in validating an early detection system, engaging patients and family through advisory boards, and conducting co-creation sessions to refine care models. And the intervention trial is in its final preparation stage, and you can follow the project evolution by scanning the QR code on this slide. I have to say that this call was for patients with non-oncological diseases, but I'm sure that it will be able to apply also to cancer patients, or at least we are trying to do so. And then the second project is Home C2P2. You will hear me to talk about C2P2. C2P2 stands for chronic complex children and palliative and pediatric palliative care. And also you see here the C3AP, that stands for Clinical Command Center and Primary Care. We call its AP is primary care in Spanish. And this project optimized the coordination between primary care and specialized care to improve home support for children with chronic complex conditions. By integrating digital tools, it aims to reduce emergency visits, hospital admissions, and length of stay. The project also explores how to adapt this model across different European healthcare systems, ensuring better integration and patient outcomes, and it will kick off next month. You can see here just a brief explanation, but how would it? Well, we are trying actually. In C3AP, we have some patients that we try to monitor, and then we receive. Not only we receive those data, but also from the primary care. So in that sense, we can decide whether the patient has to go to see the primary care physician, or maybe the nurse from their primary care can go at home, and also obviously if it's needed, the patient can come to the hospital. And this project is closely linked to Sant Joan de Déu Clinical Command Center, shown in this image. And this center plays a key role in coordinating home-based care, enabling monitoring, early intervention, and also communication between families, primary care, and hospital, and as I said. Here you can see some points on the map. This is a map of Catalonia. It's not fully seen. Here you have the Catalonia. It's a region of Spain that maybe some of you know. And we have those patients at home in this geolocalized, let's say. And then, well, as we move forward, it is essential to demonstrate the value of care models in pediatric palliative care. We have a lot of work to do. And I think international collaboration, especially in pediatric oncology palliative care, and the development of collaborative networks and creation of specialized care structures must be supported by this strong evidence to not only to ensure effectiveness or sustainability, but also to integrate it to healthcare system. And in this sense, I think you will know this Hope for Kids joint action. This is a proposal for member states led by the Princess Máxima Center and currently under evaluation by the European Commission. Its goal is to enhance pediatric oncology palliative care in Europe through international collaboration, guidelines development, pilots program. Actually, we led from our hospital this work package, and also specialized training and trying to have more evidence on long-term sustainability. And well, this will be by analyzing the current landscape and implementing structured interventions. And Hope for Kids aim to improve at the end support for children, families, and healthcare providers. I want to stop one moment to explain you about Sophia's House, that is our pediatric hospice. And well, actually, it's not a hospice. It's we call an intermediate care center or facility, and it's designed to provide specialized support for children with complex chronic condition and palliative care needs. With 15 beds, it offers a flexible, home-like environment where children receive medical, psychosocial, and respite care adapted to their needs. And in just the first 3 years, Sophia's House has already covered for more than 800 patients, reinforcing the importance of dedicated space and especially that bridge the gap between hospital and home, ensuring comprehensive and compassionate care for children and families. Also in Catalonia, we have these national and regional pediatric palliative care networks, such as this Catalan model, that highlight the need for strong coordination across all the levels. You can see here the participation of specialized teams and more regional or community resources. And this model is trying to demonstrate that this structured collaboration is key to deliver high quality and patient-centered palliative care. What I want to show you with those 2 slides is that I think it's growing and growing even faster, the development of pediatric palliative care and new centers also. But we need to have time to have evidence of the impact of those initiatives. It's easy to explain this network. It's easy to explain the Sophia's House, but we have the commitment to have evidence of the outcomes, of improving the outcomes. Well, and following these research opportunities, I think pediatric palliative care presents significant research opportunities more than these digital or model care opportunities. And in this sense, one critical area is the transition from pediatric to adult care. We will discuss in a roundtable in Helsinki. So we have to ensure this continuity without disruption. And I know from SIOP, you are very committed to this target population, to the AYA population. And also perinatal palliative care can also require a comprehensive approach. Maybe it's not necessary to mention, but are some of those opportunities, like also the integration of healthcare with social educational systems, as children with complex conditions need a coordinated model connecting hospital, schools, and social service. We still have to, let's say, fight against those silos that are sometimes against the multidimensional model that we try to approach. And also in this sense, additionally, these multicultural aspects in pediatric palliative care that requires cultural and religious sensitivity, has been said before in Lorna's session also. And well, you are warmly invited to join our children and young people reference group at the APC, where I think together I am confident those needs will be addressed. And well, definitively to advancing pediatric palliative care research, we need to protected time. I don't know specifically in other countries, but in Spain, research conditions remain challenging and limiting the ability to generate high-quality evidence. But on the other hand, collaboration is essential, and for improving pediatric palliative care, we have to collaborate. I have said it in other slides, but a key example is the coordination between hospital and primary care. Here you can see Sylvia, a colleague of mine, and who leads the home C2P2 program. And the other are nurses and pediatricians from the primary care. And well, this partnership, I think, ensures that children with complex needs receive comprehensive and well-coordinated care where they need it most. Also, in an international point of view, or an international level, the European Children's Hospital Organization, it's a network that I think that represents this instrumental way in fostering collaboration. And this initiative led the groundwork for Palliative, actually, bringing together the 5 clinical partners and also the Erasmus University partner. And at the end, well, we tried to strengthen this global partnership because I think it's crucial, especially in those low prevalence of situations that we face in pediatric palliative care. I wanted to mention that to advance in pediatric palliative care, we also need to take action by advocating for its recognition and integration in healthcare policies. In this sense, I think that IOP is an important example, and also strengthening our involvement in European reference network, as said. It will be crucial also. Actually, in our not only the level of quality that European reference network gives to your team or to your hospital, but being together with other teams that have those European reference network, I think it's very important, and palliative care must be in practically all of the European reference network, as in this transversal way that I have mentioned. And well, I couldn't finish my presentation without highlighting the role of parents and patients. I think the voice of patients and families is fundamental to improving research, healthcare, and policy making. And as their insights helps refine legislation, create new policies, address challenges, face it in their day by day, in their daily life. And well, I think as here in SIOP, I think you have, well, we have done a lot of work involving parents and survivors. It's essential to ensuring that medical care is paired with this emotional and social support mentioned in the last presentation of Ulrika. And well, advocacy efforts must place families at the core of decision-making, fostering collaboration between researchers, policymakers, and patient organizations. At the end, to ensure that children receive the best possible care at every stage of their journey. In that sense, also our colleague, my colleague, that actually, well, currently, or he presented his PhD 3 or 4 months ago, and trying to evaluate this quality of life from the point of view of the perspective of the parents, of the quality of life of children. Well, finally, I think research should serve a greater purpose, driving meaningful changes for institutions, professionals, and society as a whole. And in that sense, institutions must anticipate future challenges, ensuring that healthcare systems are prepared to support children with complex needs. It's like I don't like to say that it's a new reality, but I hope you know what I mentioned. And professionals must be equipped to develop innovative and evidence-based solutions that improve this care. And finally, as society, we must recognize that research is not just about generating knowledge. It is about creating hope and transforming today's challenges into better outcomes for those children and families. And well, I'm sure that by working together, we can ensure that every child will receive the best possible care, support, and dignity. So thank you to the SIOP for this opportunity and to all of you for your attendance.